historically it was labeled as fever of unknown origin because at that time, during that 1950s and 1960s, we did not have so many of the investigations with us, which are so easily available these days. And apart from that, it was supposed to be labeled this unknown origin because they were unable to find out what could be the possible cause of this fever or this continuous or recurrent or remittent fever in a patient was, despite getting few investigations which were there available at that time. So when we go forward, whenever you guys would have opened your chapter of Harrison, the I would I can be sure that Aditya the log would close the chapter because they come across this huge table, and then they said, okay, no problem, we just turn one or two pages more, and then they find another this table. So these huge tables which are given in Harrison are sort of a descriptive tables and not to be read word by word. They are just trying to basically highlight what all possible causes have been reported worldwide. They, it is not necessary that if you go through these tables, you may find out terms that you may not have even heard of, or even if you would have heard of, they does not mean that they form one of the commonest causes of fever of unknown origin. And then again, the difference between these two tables is that this is fever of unknown origin and this is causes of recurrent fever. Anyone who can define what is recurrent fever? Anyone? This variation, that is, I think you are trying to tell me what is remitting fever. Is only, I think only Nilayan is attending, everyone else is not at all interested in the class. I would appreciate if you guys also participate. See, the issue with this topic is that fear of unknown origin is something of a theoretical class that you can very well read. There's nothing out of the world or something that I may tell you. The only thing is that some things, if you guys will also interact, we may have a good session. Otherwise, it will be just a basic one-way lecture. Three or more episodes in 2 months. Okay, no, that is again not right. So recurrent fever is defined in Harrison itself. 3 or more episodes of fever in 6 months is the same thing which Shiveha had told. So what I'm saying is that recurrent fever, it is defined in this chapter itself. It says that it is basically fever is recurring, but there is a fever-free interval of 2 weeks in between. Okay, so patient may be giving you history, and it is a very common history which is being given by the patients that 4 months पहले फीवर आया था, फीवर आने के बाद थोड़े टाइम बाद ठीक हो गया, फिर कुछ दिन बाद दोबारा बुखार आ गया. So in that, if the person says that I had fever 1 month back and then did not have fever for a month, then again the fever recurred, that you can define as recurrent fever. So anyhow, going apart, we do not need to go into the details of these tables. And in fact, you guys should just read the left half of this table, which I would say is infections, inflammatory diseases, malignancies, and other thermoregulatory disorders on. So that you should know that under these classifications, you can think of the causes of FUO. So if we go forward, we will see how do you define FUO. So right now, FUO is defined as this is right from the Harrison only. Thus, fever was there, which is more than 101 on at least 2 occasions, and the duration has lasted for more than equal to 3 weeks. This third point is very important, which is no known immunocompromised state. So initially, like it was defined as FUO by Petersdorf in 1961. At that time, they had taken it as a generic definition. However, later it was realized that the approach towards the immunocompromised patient is entirely different than in a patient who is an immunocompetent host. For this patient who is having uh, fever for last 3 weeks, which we are not able to find the cause for. Now, previously the definition used to be that the patient has been admitted and after 1 week of in-hospital investigation, the clinician is unable to reach the diagnosis. That was the previous definition. However, now we have decided that because it is always not necessary to get all the investigations to be done after admission, if you go through these investigations, you will find that most of these investigations can be done as an outpatient basis as well. So that is why they have enlisted that these are the investigations which should be there. And after getting these investigations, we are not able to find out what could be the cause of the illness in this patient. Okay, so if you go through the definition again, the fever is there more than 101 degree Fahrenheit on 2 occasions. We are having that is there for 3 weeks. The patient is not immunocompromised, and we have a certain set of investigations which are there, which include a CBC, a ESR, CRP. Then we will have the KFT of that patient, total protein, LFTs of the patient, which would include AST, ALT, ALP, then LDH. Then comes certain investigations which are not routinely done in every patient. We get it done in a patient when we say that, okay, the patient is having fever with unknown origin. Now, that is ferritin, ANA, rheumatoid factor, protein electrophoresis, then blood cultures are sent, urine cultures, and then we come to radiology, which is a X-ray, an ultrasound, and a tuberculin skin test. See, now tuberculin skin test is something which is more from the United States point of view, because for them, getting a positive tuberculin skin test suggests that it is tuberculosis that they are dealing with. But getting a tuberculin skin test in our country has not that much significance if we compare from the Western countries. So for us, I would not say that tuberculin skin test is there in the routine panel, but yes, we keep it. We decide that these are the investigations that the patient has already have, and we are unable to identify what could be the possible cause of fever in this patient is. Now, as we saw in that huge table, that all reported causes of FUO. So over the years, what various studies have shown is that one of them, the commonest cause would be infection, and again, infection would be some common infections would be easily picked up. Someone with, let's suppose, Haemophilus influenza or let's suppose strep pneumoniae causing a LRTI will not be having fever for continuous 3 weeks. They will have fever, will get resolved after some time. So you will find in this list, you may not need to go through it in a detailed pattern, but yes, you will find that in this list, there will be some infections which are there, which have a chronic course, which are usually not easily picked up on cultures or by the investigations, and they tend to persist in the patient, will not be causing an acute deterioration. Let's suppose if I'm saying someone is infected with meningococcus, obviously you don't expect him that without treatment he will be surviving for 3 weeks. It is not possible. However, on the other hand, if I say someone is having Lyme's disease, he can present to you after even four weeks or even 6 weeks of harboring that infection, or let's say some tick-borne fever is there or anything like that, or rickettsial infections are there. So uh, one is infection. Infection can be bacterial, can be fungal, can be viral, can be parasitic. Then we have inflammatory disorders. Inflammatory disorders, you will have basically vasculitis as well as autoimmune diseases that we know of. Autoimmune diseases, I'm sure, when someone says autoimmune, it's SLE or it's Sjogren's syndrome or rheumatoid arthritis and like that. And by vasculitis, I mean Wegener's, polyarthritis nodosa, Takayasu, and like that. Okay, so these are one of the commonest causes of fever of unknown origin. Sometimes they present with only fever without any other associated symptoms. Otherwise, if let's say if I say that a patient is a case of polyarthritis nodosa, so what is a typical presentation of polyarthritis nodosa? Anyone? Rash, fever, RPGN, abdominal pain, hypertension. Yes. Okay. Yes. Good. Glomerulonephritis. Good. Yes. Patient may be hypertensive. Patient is having fever. Patient is having dash. So yes. So this is fever is again it could be present, but sometimes the patient may present to you with only fever, with no having uh, no complaints of abdominal pain, with no GI symptoms. GI symptoms is one thing which is common in polyarthritis nodosa. So that is not there. The kidney involvement is not there initially. So that is why vasculitis remains one of the common etiological factors of fever of unknown origin. Now, if uh, let's say in Indian scenarios, what do you think is the most common cause of fever of unknown origin? And I would need at least 5 people to be answering. Okay, Nalliance is TB, TB, HIV possibly, leishmaniasis in yeast, malignancy. Okay, so I would say the commonest cause in India would be tuberculosis. You guys are right initially the way you said. Tuberculosis remains one of the common undiagnosed sort of a disease which is there. Patients come with us with fever for months, having symptoms, constitutional symptoms, and are diagnosed with tuberculosis. So the problem, but it is not labeled as fever of unknown origin because you get the chest X-ray done, you get sputum analysis done, and you usually have the diagnosis. And even if you don't have the diagnosis, keeping the clinical picture in mind and keeping the scenarios, you tend to diagnose tuberculosis early. As a clinician, when someone says that, okay, this is a case of fever of unknown origin, at that time, what strikes me is, okay, so now we have to basically go through multiple causes, multiple symptoms, multiple syndromes that could be there. And that is why the approach should be a very systematic approach. So then we come on to this, which is okay. So this is the table which is there. I would request all of you guys to go through this algorithm, which is uh, given very properly in Harrison. So what they say that this is their first part is the fever and the definition that is there. You then go and take a proper history and do a physical examination. From taking history and physical examination, you will get PDCs, a term which is used in Harrison, which is a potentially diagnostic clue. So by history and physical examination, as you guys have been taught over the years, the basic funda of taking history and physical examination is that you get certain directed clues that, okay, this is where you need to investigate further. Let's suppose someone comes to you with complaints of cough, fever, and expectoration. Obviously, you would be ordering a chest X-ray first, then an ultrasound abdomen. Similarly, someone who is coming to you with pain in his flanks, with burning exudation, you would want to look at a USG KOB. So that is why history and physical examination always guides you towards what is the system that you need to investigate. Okay, and one of the common scenarios practically that we guys come across is that whenever someone who's you can very well understand someone who is having fever for 3 weeks would have consulted at least 2 or 3 doctors and 5 other relatives and would have taken few other medicines and all sort of alternate medicines as well. He or she must have, if you take proper history and a detailed treatment history, you will find out that he or she have taken, let's say, a course of antibiotics, most likely as azithromycin or cefixime or augmentin like that, and then would have taken another course of some other antibiotic advised by someone else, would have started a treatment from somewhere, stopped it in between. Someone would have advised him steroids, a very common practice in our country. uh, you will find it that people who are sitting in peripheries are very loosely prescribing steroids without even reaching a diagnosis, because steroids remain the wonder drug for everyone. If you, for people who are, that the jhola chap doctors that we label, the people who are basically quacks. So the purpose of quacks is that they have to basically relieve the symptom. They are not interested in diagnosing the patient. So what they do is that they give out some medicines which will have instant relief. After you give steroids, steroids will treat almost, I would say, 95 to 98% of any diseases that the patient is having. It will basically resolve or it will suppress the symptoms and the patient will feel fine for, let's say, 3 days, 5 days, 6 days. It may be the treating, glucocorticoids are used as treatment in many diseases, but however, in most diseases, what it does is that it just suppresses the symptoms and allows the disease process to carry on. And then once the effect of steroids is tapered off, the patient flares up and deteriorates and then presents to the tertiary hospital. So that is a very common thing that you will find when you go through the prescriptions or the old records that the patient will be having. And this is something which would be documented by some small, some doctors or some even Ayurvedic doctors who are giving allopathic medicine. Similarly, there will be patients who would have taken alternate medicine. So you have to ensure that all of that has been stopped. The reason for stopping this is that because right now, even after giving antibiotics for 2 or 3 weeks or after giving treatment, the patient is not responding. So right now you need to evaluate him from a fresh perspective. The second reason that you need to stop antibiotics is that one of the common causes of fever could be drug-induced fever. Uh, when I say drug-induced fever, what do you understand by the term drug-induced fever? Anyone? Drug-induced fever? Not with anticholinergics. I would not say that. That is one of the, okay, you can keep it as one of the causes of drug-induced fever, but other causes of drug-induced fever is something patients who are taking medicine. It could there is obviously a huge list given in Harrison of the drugs which can cause fever. Now, what happens is that patients who are taking these develop sort of an allergic reaction to it, develop eosinophilia, and start having symptoms. And one of the common classes of drugs which cause fever is antibiotics, almost most commonly being beta lactams, and there are other antibiotics as well, which cause drug-induced fever. So that is why you need to stop these ongoing treatment because they can itself be causing fever. After that, the obligatory investigations, which we have discussed already in the definition. Then these things exclude manipulation with thermometer, can be there in Munchausen and all. And then stop and replace medication to exclude. Yeah, stop the medication to exclude drug fever. One thing that you guys should note is that drug fever, usually, if let's suppose someone you are suspecting that, let's suppose the patient was taking augmentin. So if the patient was taking augmentin, and you have stopped augmentin, the drug-induced fever should subside by let's say 72 or let's say 4 days after stopping the potential drug. If that is still not responding, that means that it was not related to at least that drug. It is not a drug-induced fever, because if you have stopped the drugs, the fever should have subsided. Okay. So then we come on to the next part, which is more important, and which, see, after getting these investigations done, normally the clinical scenarios that we come across is that the patient is having bicytopenia, pancytopenia. So that gives us two differentials. Like if I say the patient is having pancytopenia, what all things that you would keep in differentials? Let's suppose we get these investigations done, and in these investigations we find the patient is having pancytopenia, and rest all, I would say, the KFT is normal, the LFTs are normal, LDH is slightly raised, and ANA, rheumatoid factor, everything else is normal. What would you keep in mind? With obviously the history of fever for 3 weeks. Bone marrow examination should be done for pancytopenia. See, okay, that is one of the investigations, but I'm talking about, yes, like this, yes, parvovirus induced bone marrow suppression, okay, tuberculosis, histoplasma, brucellosis. Sarcoid sarcoid will present as pancytopenia very rarely, but so that is what lymphoma, malignancy, yeah, right. So that is what you start to think of whenever you get a picture. You start to think in that direction, but after getting these investigations, when you are not able to localize or would say, okay, this could be the possible cause. See, if I say that protein for electrophoresis is positive, obviously you will start to work up the patient for multiple myeloma. That could have been the cause. If I say ANA was positive, then you would want to run the whole profile of the ANA to find out what could be the possible cause of this, and then the diagnosis would be reached. We proceed forward when we see that CBC is normal, KFT is normal, uh, uh, CBC is normal, KFT is normal, this or slight derangement is there, then LFT is normal, ANA is negative, RF is negative, X-ray you could not find anything, Am I audible now? I'm sorry, the internet got disconnected. Okay, so okay, so I was telling you about the PDCs which are there. So if some diagnostic clue is there, you go for that and you confirm with your confirm the diagnosis. Now, let's suppose let's suppose now you are unable to find anything from the investigations. You are not able to get from the history. So what you do is that you go for cryoglobulins and you go for fundoscopy. Now, by fundoscopy, what they are trying to rule out is that a possible cause of infective endocarditis, you may see certain signs on the retina, or sometimes you may find anything on the a general eye examination only. I would like to say a slit lamp examination. You may find uveitis and all, which could be associated with one of your autoimmune disorders, or it could be associated with tuberculosis or chronic infections. And cryoglobulins, where do we look for cryoglobulins? In which conditions do we find cryoglobulins? Anyone? Hep C related, good. AIHA, okay. Autoimmune hemolytic. Which autoimmune hemolytic anemia will have cryoglobulin? Polyhydramnios is very good. Hep B is not that common, but yes, you can see C. Yes, multiple myeloma, CLL, Waldenstrom. Yeah, good. So that is why it is a very important investigation, which we commonly don't get it done. But one of the important. So basically, if you just break down FUO, it would seem very simple, but it is not easy to reach the diagnosis, because you would say one is the first set of investigations, which is given in the definition. Then you get the cryoglobulins done, and then if you're not able to find something, you go for a FDG PET. And if FDG PET is also not giving you anything, you go for a we'll find further, which is a CT. So if you go by this, then it is basically 4 investigations that you need to get it done. But however, if the patient is not responding to your treatment, these investigations are also not always helping you with the diagnosis. Now we come to FDG PET. FDG PET, I hope everyone is aware of what uh, the funda behind getting a FDG is. That at the time of inflammation or at the time of infection, the uptake is more of that glucose. So if you are finding some abnormalities or some increased uptake at the scintigraphy, what will happen is that then you have to confirm the diagnosis by getting a tissue from that site. So you go for a biopsy and most likely land up with a diagnosis. If you're not able to get a diagnosis, what you'll do is that you will now go again, revisit the patient, take another history, take proper examination. Sometimes what is happening is that patient has presented to you and you have taken the initial history, you have taken the initial exam, you've done the initial examination, and you're finding nothing is remarkable. However, once you start investigating the patient, once the patient is with you, and sometimes you examine the patient, let's say 4 days down the line, 5 days down the line, and you sometimes find new things on examination, new things in history. Uh, I would just like to share a case that we had few days back. A patient who had, it's not related to PUO, but I'm just giving you a clinical example. So we had a patient who has come to us with raised AST/ALT, and it was not an acute process. It was happening with him for last 4 to 5 months, and he was giving history that it used to come down after some days after some medicines. He was obviously not telling us the details. Then what used to happen was that initial history examination, everything was fine. Ultrasound, we could not get anything to suggest of any obstruction or anything like that. And then subsequently, the patient was with us. We were treating him symptomatically. Then on further history taking, after 4 days, we came to know that the patient used to take the alternative medications. So the patient was most likely having derangements because of drug-induced liver injury. So, and then we found out that after stopping that, AST/ALT used to normalize, but then again it used to increase once he used to restart taking the medicines. So this is one example. Then if you say physical examination, there have been instances reported where patients uh, just hold on for a second. Yeah. So there have been cases like patients who are presenting to you with fever, with hepatitis, and with deranged KFTs. And initial examination, you're not finding anything on X-rays, you're not finding anything on the ultrasound. We have seen cases where 5 days, 6 days down the line, when someone examines the back of the patient or the abdomen or the thigh region, they find a S-char, which gives you a clear-cut diagnosis of scrub typhus. So that is why revisiting the patient, revisiting the history and physical examination also holds an important step. Yeah, principle of scintigraphy is this only, that what they do is that they see, scintigraphy and FDG PET are slightly different, but they are like this labeled leukocyte scintigraphy or gallium scan. It is also based on this radioactivity only. They give a radio labeled gallium, and then that is uptaken at a place where there is inflammation and infection. And similarly, this labeled leukocyte scintigraphy is also this, that they label the WBCs, and then obviously at the area of inflammation, these they will light up. So that is what scintigraphy or FDG PET. Initially, scintigraphy was introduced, but now with the introduction of FDG PET, we don't go for scintigraphy that common. So once you have done FDG PET, if you're finding abnormality, you go for a diagnosis. If you're not able to find, you revisit. You did not get. If you're, let's suppose you're getting something, you go for that. If you're not getting something, then you need to go for CT scan. You need to image the patient. You go for chest and abdominal imaging. Harrison itself writes that if you are having a patient who was having a normal chest X-ray and a normal abdominal ultrasound, the chances of, and plus you are having a normal FDG PET, chances of finding something on chest and abdominal CT is also very less. The chances of picking up something new on a chest and abdominal CT is also very less. But it does form one of the important investigations. Then another thing which is written is temporal artery biopsy. Now that has to be done in patients who are elderly and are giving symptoms suggestive of chronic headache, which is to diagnose your giant cell arteritis. But that is only in elderly, not in young patients. Now again, if you're still not able to reach the diagnosis, you assess the patient. If the patient is stable currently, we'll go to the treatment wala part. Let's suppose the patient is not stable. Now this is written at the end of the algorithm, but this is applicable throughout the workup. Whenever you think that the patient is deteriorating and you're not able to reach the diagnosis, then like we had discussed for initially, that people used to give glucocorticoids. Similarly, you may need to start certain things empirically for that patient if you're not able to reach the diagnosis. That is known as a therapeutic trial. There have been instances where you are not able to decide whether the patient is having tuberculosis or not, whether the patient is having certain disease or not. Then what you do is, the only way to decide sometimes is that you start giving the treatment for that. And if the patient responds, then we conclude or we confer that that was because of the tuberculosis only that the patient responded to ATD. Okay, so I would say after that, once we are done with these, the role of liver biopsy and bone marrow biopsy is very limited. Reason being, liver biopsy in itself is a very procedure, fraught with complications. It's not easy to do a liver biopsy of every patient. You need to have proper technique and have proper infrastructure to get a liver biopsy done. And once you go for a liver biopsy, you need to monitor the patient as well. There have been instances reported that the patient used to be stable before, but developed some complications secondary to liver biopsy. So that is why liver biopsy is only needed if, let's suppose, you are getting something abnormal on the liver, or sometimes you're suspecting a chronic infection that you can pick from a liver biopsy. Similarly, bone marrow biopsy also, if you're not getting anything on the hemogram, hemogram is normal, the bone marrow biopsy would not yield much. Like one of you guys mentioned that someone who is presenting with pancytopenia, yes, obviously in that cases we look for certain other parameters like retic count, like peripheral smear, and then if there is some indication, we go for a bone marrow biopsy in those patients. But it is not a routine investigation which is to be done. It used to be done previously, but right now it is not advisable. So lastly, we come on to the treatment part. Treatment के लिए colchicine has been used initially for patients who used to have familial Mediterranean fever. NSAIDs is something that is being given as a, like you would have noticed in the algorithm as well. A patient who you are not able to reach the diagnosis and stable, you can give NSAIDs. NSAIDs obviously will reduce the inflammation to some extent. Commonly, we can give naproxen. And lastly is glucocorticoids. Glucocorticoids is also to be given once you are able to rule out that there is no sign of any active infection. And you can give glucocorticoids in monitored doses with a regular follow-up, so that you are able to check whether there is no flare-up, plus the symptoms are also relieved. There have been times where the patients have been just given NSAIDs and the patient have responded to NSAIDs, and you may not be able to reach the diagnosis, but the patient is symptomatically relieved and are doing well on follow-up as well. So sometimes you are not able to reach the diagnosis even despite getting the whole battery of investigations following all the structured programs, but is responding to a symptomatic treatment. That can also be possible. Okay. So I would say that could be it. That is the maximum that can be done to summarize the case, this class. Okay, any other questions you can put up, so after that we can close the class. How to differentiate between infection and inflammation based on lab findings. So see, differentiation between infection and inflammation is again based on the history. First of all, obviously both of them will be having fever, but a patient who is having infection will have more of a high grade fever. Inflammation will have slightly low grade fever, not associated with chills and rigors. Also, on the lab findings, I would say that an inflammatory disorder will not have leukocytosis that much. Yeah, infection does cause inflammation, but I get what Swati is asking. See, obviously, okay, if I ask what is pancreatitis, what do you understand by pancreatitis, acute pancreatitis? It is an infection or it's an inflammation? Yes, it's an inflammation. So exactly. So obviously there is a difference between acute pancreatitis is inflammation. However, if I talk about pneumonia, you also know that it is an infection. So it is more of a clinical scenario plus what you find on lab findings. If I'm finding increased counts, I would if I'm finding raised procalcitonin levels, if I'm finding raised lactate levels, I will think that this is more of an infection. However, inflammation will have raised acute phase reactants. That can be there in infection as well. I'm not saying that. It is not all black and white. Like you cannot definitely say that this is this. If let's suppose TLC is, it is definitely infection. No, that is not the case. However, but infection and inflammation is differentiated on this basis only. The fever would be like a patient of liver abscess will have fever with chills and rigors. However, if the patient who is having inflammatory joint pain, or let's suppose who is having pancreatitis, usually pancreatitis patients will not be having fever. Or let's suppose rheumatic fever, it's an inflammatory disorder. We'll be having fever, but then it would be a slightly a low grade fever, not associated usually with chills. Okay, so that is how, and based on the findings, like I said, ESR may be raised in inflammatory disorders, which is usually normal in an acute infection. Okay, anything else? Any other questions? See, this was more or less sort of a theoretical class. We could not discuss uh, because obviously you guys also don't come across these patients, so it is difficult to present a case of fever of unknown origin. But yes, obviously you need to go through the algorithm. That is how you need to approach the case, and you should know that what is the order of investigation. Anything else? In situations where steroid can flare up infective pathology, we have to rule out between these two. See, again, let's suppose if let's say if we're talking about something, we are suspecting that there may be a active infection. Obviously, giving steroids at that time could be catastrophic for the patient because that could lead to a flare up of the infection and then further deterioration. So obviously, you need to rule out now active infection. If you start to think of active infections would have some common sites. If you go and read the literature, you would find that respiratory is the commonest site overall, if I talk about, and that is closely followed by urinary tract infection. Then other infections could be abdominal GI infections, or then could be skin infections, or it could be a CNS infection. So, you have got a chest X-ray done, you have done an abdominal ultrasound, you have got a FDG PET done. Now, if there is no uptake on FDG PET, you can be rest assured that most likely we are not dealing with inflammation or infection anywhere. When we are not having any increased uptake on FDG PET, or when I'm not saying that you need to go for FDG PET to rule out inflammation and infection. No, that is not what you should be inferring. What I'm just trying to say is that when you are not able to find out anything on the imaging, so then the chances of any active infection lying there becomes less and less with each and every normal imaging report. So in such patients, obviously you can give steroids. However, if you are suspecting, let's suppose, let's say I got a CT scan of the patient and there is a lesion on the CT scan, and that could be a possible infection. We still don't know what is the infection, but we know that the patient is having fever because of that. Okay, let's suppose if I explain this further, the patient who has come to you with fever for 4 weeks is having more than 101, is not immunocompromised. After getting the investigations, you find that the counts are slightly raised and we are getting this lesion on the chest X-ray, but we are not sure why, what is the etiology of that lesion. We get a CT scan. This also says that this could be a sort of a, I would say, a collection is there, or I would say a consolidation sort of a thing is there, and that we still don't know what is. There is no lymphadenopathy, so you won't be suspecting tuberculosis, and we are stuck. We don't know what is causing this, and already patient has received antibiotics from outside because someone would obviously make a diagnosis of LRTI and give the treatment. So the patient is right now with you, is not having a resolution of the symptoms, is not having still continues to have fever and is having a lesion on the chest X-ray or on the CT as well, and you don't know what is the etiology behind that. So what would be your next step? Your next step would be to go and biopsy that area, find out what could be the possible cause. Instead of in such a scenario, you won't be thinking of, let's suppose you biopsy that area and you find some granulomas in that area. Whether there are some lymphocytes are there, which will now suggest that this could be a possibly a chronic infection or could be a inflammatory disorder. So in such cases, you can give a therapeutic trial of steroids because you know that the active infection is not there. However, in biopsy, you find out something to suggest that this is acute infection, then obviously you need to give antibiotics to that patient. Let's suppose you localize some organism, you have to then give specific treatment. So anything else? Or can we close? Okay, so I think that should be it. Uh, okay.